Emergency medicine is more than just ordered chaos.
From the recess room to the bedside, we are witness to it all.
And we're here to help you prepare for it.
Bringing you the brightest minds in emergency medicine from around the world for trusted, tried, and true free open access medical education.
I'm Dr. Anton Hellman.
And I'm Dr. Katie Lynn.
Katie, let's welcome the listeners from our amazing EM community to the Emergency Medicine Cases podcast, shall we?
Yeah, or let's simply call it EM Cases.
Okay, EM Cases.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricaid, the experts in complex physician scheduling since 2012. I've been using Metricaid's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricaid helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricaid.com/emcases to see how Metricaid can make your scheduling fair, improve your sleep, and your performance. That's metricaid.com/emcases.
In 2017, almost a decade ago, I attended the fantastic SMAC conference in Dublin. One of the really thought-provoking debates for me was titled, "Is Emergency Medicine a Failed Paradigm?" with Scott Weingart arguing that it was a failed paradigm. Scott eloquently explained that the system is forced to serve both critically ill patients and those with less urgent needs, which creates a mismatch between the skills required and the actual day-to-day work, and this leads to cognitive dissonance and burnout. Simon Carley, on the other hand, countered that EM's ability to adapt to the increasing demand on EDs is our strength and not a failure. He argued that adaptability is our superpower, that the core purpose of EM is to provide care for anyone who presents to the ED when they feel they need it, that we're a safety net for the healthcare system, and the generalist approach is crucial for triaging and treating a wide variety of conditions and uncertainties. And we're really good at this. They proposed a variety of potential solutions for the so-called failed paradigm. Essentially, it was either narrowing the specialty to focus solely on resuscitation and acute critical care, or train doctors to handle the full scope of ED care, or restructure the system to separate the critically ill from others. And I remember at the time siding with Simon Carley on that debate, feeling very proud to be an ED doc and that I could handle anything that comes through the door, increasingly honing a wide skill set, embracing lifelong learning. I love the idea of an outward-facing ED, a sort of modern-day secular sanctuary, in the words of my mentor, Howard Ovens, who's been on the podcast many times. You know, a safe place to turn for care and comfort when nothing else is available. But now, almost a decade later, I feel myself agreeing with both Simon Carley and Scott Weingart, because I think I can safely say that all of us in emergency medicine feel super frustrated and overwhelmed by the massive volume of patients we need to care for who have fallen through the cracks of our healthcare system, but we don't have the resources, knowledge, or time to care for them properly in the ED. It's gotten to be too much. And as Weingart predicted, the current situation I've described is probably at least partly responsible for the 25% attrition rate in emergency medicine in the US and the 20% attrition rate in Canada since the pandemic started. Now, this is where primary care comes in and our relationship to primary care comes in. Emergency medicine and primary care are two specialties that serve the same patients but often live in different worlds. In one, you've got longitudinal relationships, continuity, and prevention. In the other, you've got rapid diagnostics, resuscitation, and a revolving door of undifferentiated complaints. But here's the reality. Our patients don't live in silos. They come back and forth between their primary care physician and the ED, and whether they fall through the cracks or get the care they deserve depends on how well we, primary care and emergency medicine, work together. Today, we're going to unpack the tensions, explore the pathways, and highlight solutions that primary care and EM can own together. How do we triage, communicate, and share data better? What funding models make sense? And most importantly, how do we build relationships that serve patients across both acute and chronic care needs? So there'll be no turf wars today, just collaborative conversation about making the system actually work for people it's supposed to serve. We'll define what right care, right place means in this context, learn from global models, and drive home 5 concrete action items you can do this month to tighten your ED primary care pathways for better, less frustrating care, no matter where you practice medicine. And to help us do this, we've got 2 very special guests on EM Cases, Dr. Tara Kiran, a family physician and researcher who's passionate about building a stronger, more equitable primary care system in Canada. She practices at St. Michael's Hospital, Unity Health in Toronto, where she's also a scientist at the MAP Center for Urban Health Solutions. In 2022, Dr. Kiran launched Our Care, a national initiative to engage the public in shaping the future of primary care in Canada. And she's a fellow podcaster. She's the host of the fantastic podcast Primary Focus. Dr. Danielle Martin is the chair of the Department of Family and Community Medicine at the University of Toronto and a practicing family physician at Women's College Hospital. She's a founder of Canadian Doctors for Medicare, bringing a national lens to equity and access in primary care, and she's the author of Better Now, 6 Ideas to Improve Healthcare for All Canadians. Previously the executive vice president and lead medical executive at Women's College Hospital, Dr. Martin helped launch Women's Virtual, Canada's first virtual hospital. Welcome to EM Cases, Dr. Kiran, and welcome, Dr. Martin.
Thank you. It's great to be here.
All right. Let's start off with some myths and misperceptions about how EM and primary care operate in our healthcare systems. What we'll do is we'll start off taking turns alternating between the 2 of you on, let's say, your top 3 myths and misperceptions about the best way to provide primary and emergency care to patients. And then we'll dig deeper into each of those things as we go through the podcast. So let's start with you, Dr. Martin.
Well, one of the myths that I grapple with as a primary care clinician is the myth that the reason that emergency departments are crowded is because too many people are showing up with problems that could have been dealt with in primary care. Now, of course, we know that there are people who come to the emergency department with issues that could have been dealt with in primary care, and they come for all kinds of reasons, sometimes because they couldn't get in to see their team, sometimes because they couldn't get in at a time that was most convenient to them, sometimes because they're scared and worried about something that you and I might not find scary or worrisome. But none of those things is what causes crowding in the emergency department. In almost every developed country in the world, emergency departments are crowded because they are full of patients who are waiting for a bed upstairs. And they're waiting for a bed upstairs because it's hard to discharge people who are ready to leave the hospital. And we can't get enough access to other resources in the community. And so that blockage in the system is not the result of the twisted ankle or the sore throat that's landed in the emergency department. It's a system-level problem. And I hate it when it gets laid at the feet of patients with what we perceive to be non-emergency problems coming to the emergency department.
Yeah, absolutely. We did a very long, deep, complicated podcast on overcrowding and access block. And in the title was Access Block, which is exactly what you're describing, is that access block is the key determinant of ED overcrowding, not people who have minor problems coming to the door.
Yeah, maybe I'd just build on what Danielle said, because I think this really came to light in a way that was really terrible for actually a lot of family doctors during the pandemic. We had media, senior health leaders, people in government who basically said the reason that emergency rooms were crowded was because too many family doctors were seeing patients virtually. Their offices weren't open enough to in-person care. And, this even got to the point in our jurisdiction in Ontario where the chief medical officer of health, along with others, issued a statement saying, you need to basically see more people in person, family doctors. And, in fairness, actually, the government did ask us as researchers to take a look at the data to see, is this narrative out there actually based in fact? So when we looked at the data, one of the things that was really interesting to see is that, first of all, actually, emergency department volumes actually weren't at pre-pandemic levels during the first 3 years following the pandemic. And so the issue for emergency department overcrowding wasn't actually that there were more visits to the emerge, because there weren't any more visits than there were previously. Instead, I think there were issues, as we've talked about, with staff shortages and, all the things you've probably talked about in your podcast on access block. But what we also found is that, family doctors were seeing lots of patients, both virtually and in person. And in fact, when there were high numbers of COVID cases, there was a lot more virtual care being provided by family doctors. And at the same time, the volumes in the emergency departments were actually lower. And that makes sense because we told people when COVID cases were high, don't go in if you don't need to. And so instead, though, I think the reason I bring this up is because I think it, also illustrates that people are very quick to blame family doctors sometimes for health system problems without looking at the data in detail to see, is this actually borne out in truth?
We got some hard data there that disproves what most emergency physicians believe, I would guess, and that is a great first myth. Let's go with a second myth or misperception.
All right, maybe I'll kick us off here just to say that. So we're in a situation specifically in Canada where not enough people we're in a situation specifically here in Canada where too many people don't have access to primary care. So some of the data that we collected through Our Care suggests that it's more than 6.5 million people in Canada don't have access to a family doctor or nurse practitioner that they can see regularly.
Okay, and for those of you listeners who are from other countries, the population of Canada is about 40 million. So 6 million of those people don't have access to primary care.
Yeah, so it's about more than 1 in 5.
And this is a problem not just in Canada, but in many countries. Some have worse statistics than that, some have better. But I think medical professionals from other countries see Canada as this amazing place that provides amazing care to everyone. And it's actually a bit surprising to know that 6 million Canadians don't have access to primary care.
Yeah, it's really terrible. And we can talk more about the implications there. But I think one of the things that you hear is that, if we get everybody access to primary care, that's going to mean emergency department visits go down. And it's true that supporting people to be healthier over a long term is going to mean less use of other parts of the healthcare system. But at the same time, we're not going to necessarily see an immediate effect on emergency department visits. There have been some really interesting studies, like in the US, where people got access to primary care. And after getting access to primary care, actually there was an increase in emergency department use because people actually had a lot of unmet health needs for many years. And when they started to get access to primary care, those unmet health needs were uncovered. And sometimes family doctors were like, actually, no, you need to go to the emergency department and get care. And so I think we have to be careful when we're thinking about what are the reasons why we're investing in primary care and how are we measuring success. I worry when governments look to measure success in primary care by just looking at emergency department visits.
And if I could just add to that, because I completely agree, I think that, the inverse is also true, that having access to a family doctor, a GP, a nurse practitioner, a primary care team may or may not reduce the likelihood that you show up in the emergency department with the proverbial sore throat or twisted ankle. And I don't think we should worry too much about that, to be honest. What we know it will do is, over the next 10 years, make you less likely to have a stroke because we will help you to control your hypertension and your diabetes. It will make you less likely to get readmitted to the hospital because we will help to control and manage your chronic lung disease. And so, the impact of primary care on the health of a population happens over years and decades. And I worry that the focus of policymakers very often, and sometimes of our colleagues who work in the acute parts of the healthcare system, that there's a misperception or a myth that if you have good access to primary care, you're going to stop using other parts of the healthcare system right away. And as it turns out, we may discover you need to use the health system more for a period of time, but over the course of your lifetime, your utilization will go down, your chronic diseases will be better managed, your quality of life will be better. We are in it for the long term. in family medicine and primary care. That's our job in the healthcare system. And we need to help people to take a look at that longer time horizon when they're assessing, for example, what is the return on investment in opening up a new primary care team or graduating a bunch more family doctors from your medical school or whatever the case may be.
That's a really insightful clarification. All right, we've got 2 myths and or misperceptions down. Let's do one last one because we've got lots of ground to cover in this podcast. Dr. Kieran?
So this is actually one that I was thinking about when I was listening to your introduction. And I was thinking about my own conception of how we structure care in Canada and our assumptions around how we should be structuring it in the role of the emergency department. So I think we think about emergency departments, to your point, as like that safety net, that place where anybody can go at any time and they will always be able to get care. And that's a lovely thing in many ways, but we've talked about some of the tensions there. You've talked about some of those tensions. And so in some ways, I feel like the myth maybe is like that is the part of the healthcare system that is like the open door. Can we think about another part of the healthcare system or as the open door? Can we think about a primary care system that is the open door for many, with the emergency department being there next to and supporting that primary care system, as opposed to the emergency department being the one open door? And I've started to, my own thinking around this, I think, has been challenged partly through my visits in countries like Denmark and the Netherlands, and we'll talk a little bit more about that. But in those countries, family doctors are the front door for everyone. Everyone has a GP, and you actually can't go to the emergency department unless you see a GP first. And, we can talk about how they structure it to be that way, but it means that, no, not everything is coming to the emergency room, and that emergency room doctor is not dealing with all sorts of non-urgent issues. And so I think that we've structured our system in a certain way, and it worked for us for many years, and it's no longer working for us. And so I think the myth here might be just that, the emergency department as it's structured is the way it has to be. And I don't think that that's the case.
Yeah, we're really going to have to think about overhauling a lot of stuff.
Yeah.
So with overhauling a lot of stuff in mind, I think we should dig into some specific solutions and dig into a little bit deeper about exactly why all these problems are happening. So let's start with how to reduce avoidable ED use. Again, this doesn't contribute in a significant way to overcrowding, but it is something that we do want to strive for the patient's benefit, right? So if you could flip a single system lever tomorrow to reduce avoidable ED use without harming access and ensuring continuity of care, what would that be? Dr. Martin?
I think it would be a rational, neighborhood-based approach to same-day care for people who feel they need it. And that can be structured in any number of ways. In other words, no one expects the individual GP or family physician or team to work 24 hours a day, 7 days a week. But to the point that Tara was making about, we've imagined that the emergency department is the place that's always open and the door that's always open for everybody. What if there were another door that was always open? And what if that door, it could start with a phone line, it could start with an online tool, it could start with a well-constructed public chatbot option, it could start with, any number of different interfaces that would support an individual who feels they have an urgent issue to either take care of themselves or to see their family doctor or team the next day and give them an appointment to do that, or to speak on the phone live with a qualified clinician, or to be seen in person by a member of the team who has access to their chart and has the capacity to communicate back to that person's regular team, or, if necessary, a direction to go to the emergency department. But I think it's about having a comprehensive strategy that begins with a person saying, I don't feel well, I think I might need to be seen today, and having clarity about where to go first that allows for the possibility of new pathways being constructed. The way that I have put this, and I know this is Canadian lingo, is we have a system right now where all roads lead to the emergency department, and we need to lay down new roads to other locations through a single door.
Love it. So basically a rational, comprehensive, neighborhood-based entry mechanism into the system. Great. And Dr. Kieran, if you could flip a single system lever tomorrow to reduce avoidable ED use without harming access and ensuring continuity of care, what would that be?
Patient and public education and empowerment. Through our care consultations, we interacted with many people across the country. And one of the things we heard over and over again with them is, when they took part in our processes or deliberative dialogues, there was a lot of education provided to them. So they spent often 30 to 40 hours with us. And a big portion of that was learning what primary care is, how the primary care system works. And they left those interactions feeling so grateful, actually, for that education. Some of them said, we thought we knew a lot about the healthcare system, and actually we didn't. And, all of the groups that came together, they all recommended that we need more patient education and public education about how the healthcare system works, and also how people can take care of themselves. Not everything needs to come to the emergency department. Not everything actually needs to be seen by a health professional at all. Somehow in Canada, and I think sometimes in other countries too, we've actually designed pathways for people, even when they have minor ailments, that they, you have a minor ailment. Okay, maybe you can't see your family doctor, see a pharmacist. Right now, for example, in Ontario, you have a red eye that you think is conjunctivitis. Most of the time it's viral and it needs no treatment. But you can go to the pharmacy now and see a pharmacist, and the pharmacist is paid for that visit, and they could give advice to the patient and tell them what over-the-counter medications they could use. But, what if we actually gave that information to the patients directly? Like actually educated them on a easy to use website, social media, really try and put forward education that supports people to manage their own health in a variety of different ways. And I will say, when I've talked to people about this idea, people also bring this back down to even our primary school and high school education. How much health literacy are we teaching our young people? Do people know what to do when they have a fever and when it is that they should be going to the emergency department? We saw this again play out during COVID. People didn't know what to do. And as it turns out, we should have been able to give people tools to self-manage and be clear on when it is that they needed to seek care, but that was often not available. So if I had to switch one system lever, it would be to educate and empower patients in the public.
Yeah, education. It's something I kind of sort of believe in myself. All right. So those are some system levers, and we can talk a little bit more about each of those. I want to clear away a few things first, and that is a few definitions, because I kind of feel like no one can really decide together what an emergency is, what an urgency is, and what a primary care sensitive condition is. Because unless we all can agree what those things are, we can't put in place any systems where we can then tell patients which one of these things it is and where they should go. How do we sort of translate those definitions of emergency, urgent problem, or primary care sensitive condition? How do we translate those definitions into navigation guides that, front desk staff, nurse advice lines, virtual visits, and EMS can all understand the same way?
This is tough if we want to figure out a definition. At the end of the day, though, I do think we need to think about the patient-centered lens here. And what's urgent to one person may be not urgent to another. But I think we have to accept patients' own feeling and definition of urgency and support them to get care when they feel something is urgent. Now, again, that doesn't mean that they need to come to the emergency room because something is urgent. And in fact, that's what I think we need to talk about, is what are those pathways for people when they feel that they have an urgent issue. I do think we should educate them to, understand more about what might be more life-threatening or less life-threatening and more urgent or less urgent. But I think in the absence of that education, and even with that education, we have to accept patients' own definition for what is urgent.
And I would riff on that to say that I think, so of course we can have sort of clinically driven categories and algorithms and things like that that would be used on a nursing advice line or on a website or whatever. And those are good and important, and they should be validated and evidence informed and, agreed upon categories. But I also think, we are at the end of the day in a human business. I had to call a emergency department not too long ago. I was sending a patient over, and it was actually like a super responsive emergency department. They got the physician on the phone so we could have a warm handover conversation. And I found myself explaining to her this was a gynecologic case, and I found myself kind of trying to justify my expertise to this colleague on the other end of the phone. I said to her, I just want you to know, I did obstetrics for 15 years and I've done X number of these things before, trying to communicate to her, when I send you this patient because I'm worried, I'm not just kind of sloughing her off or whatever. I don't exactly know what is going on here, but something is very wrong with this person. And I think she needs urgent investigation, imaging, etc. And I got off the phone and I thought to myself, she wasn't requiring that of me. Why did I feel compelled to justify my clinical intuition to her? And I think it's because we don't necessarily value that clinical instinct in each other across that primary care emergency department divide, or we don't assume that mutual reciprocity of valuing exists. And so it made me really reflect. And she was terrific, and the patient went, and there was indeed something quite wrong with her, and she got terrific care. But, shouldn't it just be enough for the family physician to say, something's wrong here, and the person on the other end of the line immediately says, Roger that, handover complete, send her right down, I'll be waiting for her at the door, kind of a thing. And anyway, that may be...
the answer is yes.
Yes. And this isn't a therapy session, but I do think it's important, that I had that impulse to self-justification suggests that there is something in the system that is telegraphing to me that the emergency department physician might not assume my competence or trust my clinical judgment as the family doctor in that situation, or might not assume that I worked hard, did my best, and came to the edge of my scope. So all you should need as an emergency medicine doctor is to hear me say, I'm now officially out of my depth. And so it doesn't matter whether it's urgent or emergent on anybody's algorithm. It just matters that I'm saying to you, I got to hand this to you now because I'm at my limit. And similarly, for you to hand back to me and say, I noticed that her blood pressure, her blood sugar, whatever was really off, and I haven't seen these new diabetes medications myself. I had no idea what to do. So can you take this back now, please? It's not my expertise. And for me to say, Roger, I'm on it. Give that one back to me. This is my area of expertise. So those definitions will be slippery depending on what the patient deems to be urgent, and also depending on what the primary care clinician deems to be urgent. And a system where there is mutual trust would allow for that range of definitions, I think.
Yeah. I mean, it's just simply about respect, I think, like mutual respect for your colleagues across specialties, which I think we need more and more of, and I think can go a long way to just taking better care of patients. I just want to clarify something about the definitions. I think there's the definitions from the patient's perspective, which, I agree with you both 100% that what's urgent for one person might not be for another. But it's more for all the healthcare providers. We need to decide on what the definitions are so that we could put into place these tools and pathways that make sense for everyone. And I'm not even sure that we can really agree on it. I mean, I'm just going to throw out some definitions out there.
Okay, and then we can talk about in a country that I've seen where they have actually agreed on it. I feel.
Yeah. So it's possible. This is why I'm asking this question. I feel like it is
possible.
It's definitely possible. Yeah. So one definition of a medical emergency is a sudden, unforeseen, or rapidly evolving health condition that poses an immediate threat to life, limb, or long-term function and requires rapid intervention, often in an emergency department or pre-hospital setting. Okay. A medical urgency refers to a condition that is potentially serious and requires prompt assessment, usually within hours, but is not immediately life-threatening. So, for example, an asthma exacerbation without respiratory failure, renal colic, cellulitis, acute appendicitis before perforation. Those are examples. And then a primary care sensitive condition is one for which effective, timely, and accessible primary care can prevent the onset of disease, manage early symptoms, or prevent complications, thereby reducing the need for ED visits or hospitalizations. So, for example, complications of diabetes, hypertension, otitis media. So, to me, those seem like some rational definitions that we can all work with.
Yeah, I mean, I think when we're thinking about primary care sensitive, a reminder that, these are primary care sensitive in the long term. So, for the most part, you're talking about, for example, a condition like diabetes, where over the long term, you're managing it well. You're going to have less use of emergency departments and hospitals for things like foot ulcers or other kind of complications from diabetes. Urgent and emergent to me are kind of much more practical in the everyday interface between clinicians and patients and the public. We talked a bit about urgent, and I said we need to accept the definitions that, or how patients perceive what they perceive as urgent. Emergent, I think, is actually different. And that one, I think, it's life-threatening. It's something life-threatening, as you said. And I think that one we need to teach people, because people need to know what is life-threatening when they have something that requires them to take immediate action to get help. And, I think we've started to do a good job on that with, chest pain or signs of a stroke. Now we're talking more and more about sepsis and what those kinds of early signs are. But I think they are different in that way, that emergencies is something that I think we need to teach the public how to identify.
I want to move on to triaging. So hopefully we're kind of on the same page about the definitions. How should patients move between sort of a call first nurse/physician advice line, urgent same-day primary care, urgent care centers, and the ED without sort of ping-ponging back and forth? I understand that in the Netherlands, they use practice assistants with embedded triage algorithms who can resolve common problems like epistaxis, burns, UTIs, sore throat, minor wounds, etc. And they escalate to a primary care physician or the ED when needed. And in this Dutch model, primary care physician cooperatives and call first triage keep EDs pretty quiet. How could we make this work in North America? Like, what training, supervision ratios, and scope would we need to adopt to make it work in our practice settings?
Maybe I'll just start by going over that model in the Netherlands that you mentioned, because it is quite amazing. So the practice assistant is a role that is actually a 3-year diploma out of high school. So they're not a health professional in the way that, a nurse or a physician would be. It's actually a role very specific to primary care. So this is not that they've been trained to triage people in like a respirology setting and then now they're coming to primary care. It's a very specific primary care training. And during that training, they're trained on triage algorithms, so what to do when people call for a whole bunch of different common things, but also actually on communication, how to communicate with patients. And the triage algorithms are actually designed in partnership with the Dutch College of GPs. The Dutch College of GPs is an organization that actually creates guidelines for GPs by GPs. And not all countries have that kind of organization. We don't in Canada. But these triage algorithms are actually all publicly available in the Netherlands. So there's a website and, the practice assistants can actually look them up in real time. When they're working in an after-hours care setting, they're actually embedded within the electronic medical record. But importantly, so they use that knowledge and training as practice assistants. When people call, they help to determine, is this something that needs to be seen today? Can it be seen tomorrow? Can it be seen next week? Does it need to be seen by a doctor, a nurse? Can I myself as a practice assistant deal with it? Is it something that should be seen here in the clinic, or does the physician have to make a home visit? Or is this something actually that I, as a practice assistant, can resolve on my own on the phone? So an example might be a child with a fever for one day with no red flag symptoms. That could be somebody that the practice assistant can talk to the parent about on the phone and say, well, yeah, you don't need to come in right now. Here are the reasons or times when you need to. It's a very rational model. And when I saw it deployed, you see basically, in any one setting, a number of different practice assistants working with one GP kind of overseeing or supervising. They're there during the GP practice in the day, but then they're also there in those after-hours regional centers that we talked about. And in those after-hours regional centers, you might have one GP that's actually overseeing maybe 10 practice assistants who are continuously taking calls from patients. There's like one number to call from the whole region, and it comes into to their line, and different practice assistants grab that. And if there's any questions, the GP is right there, in that call center to bounce things off of. There's another GP that's there actually seeing people in person. There's another GP that's like out and doing home visits. But it's a model that works really well, and I think actually challenges us to say, well, why don't we have that kind of primary care triage here in Canada? It's not rocket science. We know what the more common reasons are for calling in. In fact, another country has done it. Can't we just bring that over right here? So I think this is something that's very doable in terms of a number of things. The approach of a virtual first approach, which is very efficient and actually very patient-centered, to this primary care triage and having a person that is actually really trained to do that job very specifically. And I would say the third piece around that is the integration into the system and the way they do that.
And what I'd add to that is, so I was recently talking with a colleague at a conference who's from a country in sub-Saharan Africa, and we were talking about primary care priorities all over the globe and how health systems everywhere are really trying to strengthen primary care and the global human resources shortage across the whole of all health systems, but also specifically in primary care. And I said, we have all these Canadians who don't have a family doctor, and we're working so hard to try to figure out teams and everything. And he said, yeah, I know. It's hard for us too. We only have 120. And I said, 120 what? And he said, family doctors for our population of 80 million. 120 family doctors for a population of 80 million. So how do you deploy that workforce? The answer is you have community health workers in every community knocking on doors, making relationships with families, giving frontline basic health and hygiene kinds of advice, weighing babies and measuring bellies and doing that kind of a thing. And then a single physician overseeing an entire region from a primary care perspective. So I think that actually in high resource settings, which by any rational measure Canada is, although it sometimes feels like we're a low resource setting, we are not. In low resource settings, that creativity has been forced, has been there, from the outset of health system design. So just as these models exist in other high-income countries, there's also a lot we can learn from our brilliant friends and colleagues that have been inventing models in low resource settings as well.
Dr. Martin, I want to talk a little bit about what works in Canada and what doesn't, and then how we might be able to integrate a model that they use in the Netherlands into Canada. So in Canada presently, what works and what doesn't in terms of triaging?
What works in Canada and what we have always been proud of and are sort of known for, in spite of the many, many cracks and challenges in our healthcare system, is the existence of a universal set of insurance plans that ensure that medically necessary care is completely free at the point of care for almost everyone who lives here. And I don't think that we should, A, take that for granted, or B, assume it to be the norm, because we know from tons of evidence that even a $10 copayment at the door in a primary care clinic or an emergency department is enough to deter probably the person you want most to come in. You and I both most want to come in when they're not feeling well. And so ensuring that at the point of triage and access to care, people are not having to make trade-offs and choices based on their fear of a medical bill is critical. And it's sort of table stakes, but most countries in the world still don't have that. And that's insufficient, of course, as evidenced by the fact that in spite of our universal coverage plans in Canada, we still have 6 million people who don't have a family doctor or a primary care team or a GP or a nurse practitioner or whatever. And so I think, a lot of what comes after that is, okay, well, we've eliminated the financial barrier. Now the barriers are at the level of health services delivery. And that's on us, all of us as clinicians who have the option or not to participate in pushing and participating in health system reform to fix. And I always say, of course, as clinicians, our first job is to take care of our patients. That's what we were trained to do. And maybe our second job is to advocate for or push for the changes that we think need to happen in the health system to make it better. And we're very well placed to see what some of those cracks and challenges are and to point them out. But just advocating for it is insufficient. We have to actually participate in it. And sometimes that's uncomfortable because it requires us to try practicing in a new way. I mean, how do you feel about being asked as a physician to oversee a call center in the evening or go out to do a home visit to a patient if you've not had the experience of doing that before? Are you worried about your medical legal risk that flows from having a whole bunch of practice assistants making calls and then, you're flitting around the room or whatever? Are you willing to give it a shot? Because if you're not, are you willing to get in the car and go to somebody's high-rise apartment where you're stuck in a not very good smelling elevator or whatever it is? Like, I think we willing to get out of our comfort zones as clinicians and try doing things differently in order to participate in those solutions? Because otherwise it's just a lot of words on paper.
Yeah, I mean, maybe I'll just build on that to say that I think, one of the challenges that we have in primary care in Canada relates to timely access. And so one of the reasons that this model I described in the Netherlands works is that family doctors, or GPs as they call themselves there, they have a professional ethos in which providing timely access is part of their job. They think that that is just the way that they think about the work that they do. And it's actually also part of their responsibility because they know that their patients actually can't go to the emergency department unless they have a referral from a GP. So what that means is the patient has to call in, they're triaged by this practice assistant. If the practice assistant says, oh, this is something more urgent or emergent, might need an emergency room doctor, the GP gets involved, and eventually it's a warm handoff between the GP and the emergency room doctor. But all this to say is that there is an ethos and a responsibility around timely access. And it starts with that, and then they've built these systems for demand management. And that's what we haven't done a good job of here. If we want to make sure that everybody has care and people are, potentially family doctors are looking after more and more people, we need to figure out which are the people we need to see today and talk to right now versus can wait. And having something like a practice assistant role is one way to do that. Another way to do that is to integrate technology into some of that triage too. And I think there are some jurisdictions that are trying to do that. The other thing that I'll point out is that the Netherlands has designed their system in a way that is regionally based and population based. So, everybody in a specific area has one number to call and the same place to go to. And they've done that actually partly through physician leadership. It's one of the things that I think I took away from my time there was that a lot of these innovations and things that are working well are actually because physicians figured out how to do something in a way that was efficient for their community. It works for them as physicians, but it actually works for the community. And I think sometimes we can get stuck here as like, well, our responsibility is into these specific patients that we might be caring for, as opposed to how can we shape care to actually make it easy for everybody in that region or community.
So it kind of sounds like, a single trusted access point that takes the guesswork out of where to go is key. It's really such a contrast to what most of us see on shift. People showing up in the ED not because they made the wrong decision, but because the system just didn't give them a clear door to walk through. We've built all these sort of parallel entry points. We've got, nurse advice lines, we've got walk-in clinics, we've got virtual care, we've got urgent care, but without an integration or shared accountability, patients are left to sort of self-triage in this fragmented maze kind of thing. That leads us into team-based primary care and access to primary care. Dr. Martin, in your book on how to improve healthcare, you wrote about ensuring that every patient has universal access to team-based primary care, where every patient has a long-term relationship with a primary care provider, and that this reduces ED visits and hospitalizations. Can you just sort of elaborate on how team-based primary care could reduce ED visits and make it better for the patients?
Yes, I mean, this is my love sonnet to my discipline, because the reason that I am a family doctor and the reason why, despite the challenges, I love being a family doctor is that this is the discipline that is about relationships over time. And so I'm celebrating my 20th anniversary of being in my practice.
Congratulations.
Thank you. I have a very small practice because I have many other things that I do and hats that I wear. But I looked up my roster the other day. I have 502 patients, and I've gotten a little bit romantic about these 502 lives that I've spent 20 years, embedded in, and what that means to me as a person and also as a professional. And so, all of the evidence over many decades and across many health systems shows that health systems that are based on a strong foundation of primary care that is longitudinal, relationship-based, continuous, a first point of contact for people, and comprehensive in its scope, that those health systems produce better health outcomes more equitably and at lower cost. So that's why we should do it. We should do it because it's how you get a high-performing healthcare system. But we do not live in an era where a single clinician can do that for a practice population, even a teeny tiny one like the one that I have. We live in an era where A, there are not enough physicians to do it, and B, there are actually super well-trained healthcare professionals who are better at some aspects of what our job is in family medicine and primary care than I am. I would take my pharmacist 10 times out of 10 on some of the complex medication regimens that my patients are dealing with. For example, I would take the social worker on my team 10 times out of 10 for the provision of cognitive behavioral therapy over my clunky CBT skills. And anyway, it's not the best use of my time, and there aren't enough of me. So we will never get to 100% coverage of the population with a solely physician-based model, both because the other skilled health professionals in primary care have a huge amount to offer our patients and communities, and because the math doesn't math. So we've got to think differently. Doctors have to work in groups, and they have to be surrounded by teams of professionals who are also experts in their field. It's the only way we're going to get to 100% coverage of the population in the Canadian context, and I think actually everywhere in the world that is the case. And what's interesting, and I find kind of reassuring or exciting, is that if you think about in the emergency department, there are a few things that only you can do as the emergency department doctor. But there are a lot of things that you can do that the nurse can also do. And there are a lot of things the nurse can do that the RPN can also do, or that somebody else can also do. You can manage the medication, but so can the pharmacist. In other words, our scopes of practice overlap tremendously, actually, as healthcare professionals. There are some things that only one person can do and many things that lots of different people can do. That's important because in practical terms, wherever you're working, you may not get the perfect complement of healthcare workers to staff, whether it's an emergency department or a primary care team. You're going to work with what you've got and you're going to make it work. And so the overlapping scopes of practice allow for local variation according to community need and also according to actual availability. If you can't get an RN, but you can get a nurse practitioner, or you can't get a dietitian, but you can get a health promoter, if you can't get a medical office assistant, but you can get your cousin that you can train up on how to do the bookings or whatever. You're just going to make it work. I think that the future of the interprofessional team all over the world will be to come to understand what the functions are that are needed in a primary care setting, or for that matter, in any healthcare setting, and then to work with the human resources that are available in order to achieve those functions. If we approach team-based primary care by saying the definition of a team is a doctor, a nurse practitioner, a pharmacist, a social worker, a dietitian, whatever, that feels almost as unachievable as an only doctor team. What we're going to need to say is these are the functions that primary care needs to offer in order to serve a community or a population, and then we'll hold it together with paper clips and duct tape like everything else.
And Dr. Kieran, when it comes to team-based primary care, what have you found that works in Canada or elsewhere?
Yeah, I've had a chance to travel to a few different countries to understand how primary care systems work. We've talked about the Netherlands, been to Denmark over the last year, as well as Catalonia, Spain. But I've also had a chance to visit interesting practices here in Canada that I think are really doing innovative work. And also, of course, read widely about what team-based care, looks like ideally. And I'd say, building on Dr. Martin's comments, that at the core of high-functioning teams, there's often what we call a mini team. So that would be a family doctor, maybe a nurse practitioner, working together with nurses and upskilled medical office assistants. So an upskilled medical office assistant may be something like a practice assistant, as we talked about, someone who has training in being able to answer those phone calls that come in and knowing who should see what, when. But then there's also intersecting with that, the nurses who are often able to see acute conditions. So some things like a sore throat or urinary tract infection, they don't need to have a doctor see them. And often there are medical directives or things like that, algorithms that can be used to support nurses to be able to provide the care and know when it is that they need to consult a family doctor. And in this clinic in Calgary, Alberta, in Canada, they have a very unique funding model. They're actually what's called fully capitated. So they get money for every patient that is part of their team. But they actually get dinged not just if the patient goes to a walk-in clinic, but actually if the patient goes to emergency department, it comes out of their own money. So they have a huge incentive to make sure that they have timely access. And the way that they do it there is through upskilled medical office assistant who has training, again, on, answering that phone line, as well as nurses, and then also physicians working in groups. So it's not that every physician has to be on call for their patient all the time, but they're rotating responsibility among the physician group around who is it that is going to manage the acute conditions that are coming in and need more than a medical office assistant or nurse is able to provide that day. So at the core, I think that's what we're talking about with teams, is those mini teams layered on top of that with other health professionals.
Great.
And now a word from one of our sponsors, the Remote Ultrasound Fellowship. Every emergency physician knows the feeling. The patient in front of you is getting sicker, and the next decision really matters. Advanced POCUS gives you more than images. It gives you confidence. Confidence to diagnose at the bedside, confidence to decide who needs transfer, and confidence to know when it's time to call for help. The Remote Ultrasound Fellowship is a 1-year, fully online POCUS fellowship with mentorship from an international faculty and designed for busy emergency physicians. One recent graduate called it completely practice-changing. Learn more at remotepocus.com. Built for real-world decisions.
So we've talked a little bit about after-hours care, but I want to dig into that a little bit more. The success of after-hours system seems to be not just about adding hours, but about redesigning how care is organized, how accountability is shared, and how resources are distributed. Now, before we dig into this sort of redesigning accountability and resources, first, Dr. Martin, what does after-hours care look like in Canada presently, and what does ideal after-hours care look like? In other words, what kind of care should ideally be given in after-hours primary care to maximize access and efficiency and provide the right care in the right place by the right professional?
Well, this is where we might have some healthy debate and disagreement in the podcast space, which I would be happy with. Of course, the premise of after-hours care is that a high-performing primary care system should be available to people 24 hours a day, 7 days a week. That would be the dream. And that doesn't mean that there's a person sitting in my office, doing well baby visits at 2 a.m. But it does mean that if a baby wakes up with a fever and an earache in the middle of the night, there should be something you can do as a parent other than taking your baby to the emergency department, right? So I think that's kind of understood. Where I think there is tension, which is healthy, is around this question of should all after-hours coverage and care be about urgent things? I'm in clinic every Wednesday evening, and I have a group of patients who come to see me on Wednesday evenings for things that we would all agree are not remotely urgent. And most of them come because they can't come during the day. They come for diabetes checkups, they come for cervical cancer screening, they come for their depression follow-ups. And then, I also get the coughs and colds and the more kind of classic things that you would see in urgent care in family medicine. So I actually think that the dream version, and it may not be achievable in every health system all of the time, but the dream version of primary care should be that there is some element of outside banker's hours, if you will, access for things that are just routine, that acknowledge that especially people who, for reasons of the social and economic determinants of health, can't make it into the office, can't take half a day off of work, etc., can access just routine care. That may be too difficult to start with. And especially once you're into regional models and teletriage and whoever answers the phone is who deals with the issue, those things, that stuff's got to be about more urgent situations. But I do want to flag that I think the very best model would be one that we sometimes as healthcare workers, I think, sort of have a little bit of disdain culturally. I don't mean any individual person, but culturally there's a bit of disdain for this notion of convenience. Like the patient went to the emergency department for their rash because they were offered an appointment at their family doctor's office and it wasn't at a convenient time. And so therefore they're kind of being a princess about it or whatever. Well, actually, not everybody can come in for their rash during the day. And so I just think that a really people-centered healthcare system would take that into account.
Fair enough. We see lots of that in the emerge, so why not spread that across the whole system where there's just access, weird hours?
Yeah, there's trade-offs, of course.
Really, it's just getting the access in the first place. And I would argue that whether it's for routine follow-ups or whether it's for urgent problems, I think the first step is just to get that access. So I want to talk about that a little bit. Like, how do we actually build an after-hours care system where Dr. Martin's patients on a Friday night can go and get usual care from someone, or they have an urgent problem? How do we build that system?
Yeah, so I think let's start with where we are right now in Canada, which is now great. So, when we surveyed people across the country, this was back in 2022, it's just over a third of people said that these are people who did have a family doctor or nurse practitioner. So just over a third of people who had a family doctor or nurse practitioner said that that their clinic was open sometime outside of Monday to Friday, 9 to 5. So the vast majority of clinics in Canada are not providing any after-hours care. And in most jurisdictions in Canada, there's no obligation for primary care clinics to do that. In Ontario, there are some primary care models where it is part of your contract that you have to deliver that. But for most jurisdictions, that's not a thing that family doctors or primary care clinics are held accountable for. Contrast that with the Dutch model that we've been talking about, where actually part of the reason they've developed these regional after-hours centers is because historically, the doctors, the GPs, have been responsible for their patients 24/7. So that used to mean 40 years ago, 30 years ago, that they all were on call 24/7 for all their patients, which was like a huge deal. And then they figured out, actually, this is not great for us. we can provide great service to our patients and have a better work-life balance for ourselves if we come together and actually rotate coverage and cover everyone together. And so they evolved that system to become the after-hours care that it is today. But it started with this expectation, though, that they really were responsible 24/7, and we have nothing like that here in Canada. You asked, Anton, how is it that we can build this kind of system here? So I think that Danielle is right. We need to think about the two different things. We need to think about ideally motivating family doctors to provide some amount of care that's regular care, ongoing care for chronic conditions, et cetera, that is outside Monday to Friday, 9 to 5. We actually heard in our dialogues with patients, people were pretty clear, they have jobs. It's really hard to take time off of work. And actually, if you're a newcomer and, you're in precarious work, it's really, really hard to take time off to come to a doctor Monday to Friday, 9 to 5. So yes, we need some kind of piece there. But, we also need the urgent after-hours issues sort of looked at. And in Canada, most provinces and territories now have something called Health 811. So it's supposed to be like the front door. It's a phone number, but it's also a website where if people are having an issue, they're supposed to be able to call, and most of the time they get a hold of a nurse. And there are algorithms in the back end, I think, that support that nurse. But there are some key things that I think are missing there. So for the most part, the nurses don't have a doctor that they're able to turn to for advice, what the patient disposition and the advice that should be actually provided to the patient. So one of the things that's missing is nurses don't have a family doctor or other physician or nurse practitioner with more training who they can consult about advice to where the patient should go. In the Netherlands, that was actually co-located with the people taking the calls, and I think there's an advantage to that. But at the very least, even it can't be co-located, that advice should be available. And then the other important piece is that virtual triage was coupled with in-person care. So if somebody needed the in-person care, they were directed to in-person care. And, they were directed appropriately, whether that's, a family doctor in the after-hours center or whether they needed to go to the Emerge or whether the family doctor went in a taxi with the driver to the patient's home. So I think we have some of the infrastructure here in Canada that we can build on, but I think we need to advance how we are delivering virtual care so that front door actually is more powerful and more accurate and can actually direct patients in the right place, and so that it's integrated also with in-person care.
All right, let's talk a little bit more about virtual care, because virtual care has changed a lot over the last few years, especially with the COVID pandemic. There was a lot more virtual care, and there's evidence that seems to be conflicting of whether it actually works or not, how it works, what the best way is. So in your view, Dr. Martin, what is the ideal use of virtual care in Canada? And once we establish that, we can talk a little bit about virtual care in other countries and how it works there.
Sure, and I'm delighted to quote Tara's research back to her. That always gives me particular joy, but also from my own experiences as a person who did a lot of work on virtual care when I was in the hospital sector. I think in summary, the evidence actually isn't that conflicting. The evidence says that when virtual care is integrated with in-person care, it is a very effective tool in most settings. And I'll park the question of the ED. I'm sure you've done podcasts about virtual ED. And if you haven't, maybe you will in the future. But I think in primary care, some of what Tara's work and others has shown is that it appears to be that when virtual care is delivered by a patient's own family physician, I'm paraphrasing the interpretation of the evidence here, that actually can be very effective, including in not reducing increased rates of emergency department use. But when virtual family medicine care is delivered to populations of patients by a person who does not know them and will never see them again in the one-off virtual app kind of a way, that seems to, at least under some circumstances, drive more ED use. And so that kind of stands to reason for those of us who work in primary care. The shorthand of a patient calling or having a video visit with a patient who you have experience of and being able to talk through something and either give them advice and follow up with them quite soon if needed, or direct them to the most appropriate path, that relationship is a key tool. Whereas the sort of what I think of as the virtual walk-in clinic, it stands to reason to me as a clinician that since you have no capacity to see that person in person under any circumstance, tomorrow or any other day, and you have no capacity to follow them up, the likelihood that you're going to tell them they should go to the emergency department just to make sure it's not the worst possible thing is much higher. And so I think that's the first thing. And you could probably quibble with my interpretation of the evidence in some small ways, but I think that that is the general direction of travel of where the evidence leads us, and certainly what makes sense to those of us who work in primary care clinically. I will say that I think the same is true when it comes to work that we've seen done around the provision of virtual primary care, where a family doctor takes on a full-on primary care longitudinal relationship with a population of patients that they may never or rarely meet in person. And there's been some interesting work done on that here in Ontario, in which you can imagine in rural communities where it can be very difficult to recruit and retain physicians, a small on-the-ground team to do the in-person stuff using a shared electronic medical record, a doctor or a nurse practitioner at a distance taking responsibility for a panel of patients over time, seems like it actually works. And it's much better, in my view, than we can't get you a permanent in-person family doctor and therefore just use an app and see whoever, whenever it is that you think you might be sick.
So what we heard from patients in the public quite clearly in our consultations is, yes, they want virtual care integrated with in-person care, but that particularly they wanted virtual care used in a way that enhances equity and access and not widens equity gaps. And one of the use cases that people talked about is, just as Danielle said, is using virtual care to enhance access in rural and remote areas. And so in one of the episodes of our podcast this season, we take listeners actually to Renfrew County, where is a great example of this happening. The story actually starts during the pandemic when, this is a rural area that's underserved, not enough family doctors, and a small population distributed over a large geography. And they needed to figure out, how are we going to be able to, have COVID testing and assessment in this type of setting? And that ended up turning into this collaboration with paramedics and largely virtual family doctors. They had family doctors often situated in different parts of the province, supporting care delivered in person, sometimes by paramedics. So if somebody, for example, had an issue in their home and they needed to be visited they could be visited by a paramedic. The paramedic could then, if they weren't able to resolve it on their own, connect with a family doctor. Or a patient, if they had questions about what to do, they could call this line and be connected with a family doctor who wasn't based in Renfrew County, because it's really hard to recruit family doctors in that setting, but actually based elsewhere in the province. And so that model has now actually evolved to actually one where they're providing ongoing primary care too, in this kind of hybrid model where there's an on-site team and there's family doctors who are working remotely. But I think it's a really great example of how we can use virtual tools to try and address an equity gap. And in the Canadian context, one of those equity gaps really is care delivery in rural and remote areas.
Absolutely. There's a lot of EM Cases listeners that work in rural areas, and so I'm sure they'll be interested in that. So it really sounds like it is about integrated virtual care in some way, rather than just these one-offs, which seem to possibly waste money and actually drive more people to the emergency departments. In case you haven't heard yet, tickets for the next virtual EM Cases Summit are currently on sale at emcasessummit.com. Join us November 21st, 22nd, and 23rd for 3 days of the best EM Cases speakers from around the world, state-of-the-art procedural demonstrations, expert panel discussions, rural EM sessions, prize giveaways, and fully accredited CME.
It's also a great opportunity to connect with emergency clinicians from around the globe. And if you've been enjoying EM Cases for free over the years, attending the EM Cases Summit is one of the best ways to support our mission and help us continue producing free podcasts, blogs, videos, and educational resources. So please do visit emcasessummit.com for all the details and to get your tickets soon.
I want to change gears a little bit and talk about access to patient information and data sharing. So, having efficient sharing of patient information and data is key to an efficient healthcare system, and especially important in the relationship between primary care and emergency medicine. So, Dr. Martin, what are the patient information needs to improve the system?
Well, Tara's done a lot of work on this in terms of ensuring that patients can access their own information, and I do think that that's key. I will say that in family medicine and primary care, there's kind of a Goldilocks middle ground where we need enough information to know what is happening to our patients as they travel through the healthcare system. Like it's really important that we get that discharge summary when they leave the hospital or when they've been seen in the ED, et cetera. I don't, however, need 14 chest x-ray reports from the daily chest x-ray that my patient has when they're admitted in the ICU. I just need to know when they're leaving and what happened. And so there is such a thing as too much information. And in fact, that's not really information. It's just data that is of no use to me as the primary care clinician. And so I think we want patients to be able to access their own data and they can share it with whomever they want. But we also want enough information flowing to the doctor and team in the emergency department. When my patient comes to see you, you should be able to get enough information to know, for example, what medications are they taking, what chronic conditions have they got, why were they advised to go to the emergency department in the first place. But you don't need to know that they came to see me 3 years ago for whatever skin problem. And so you want the right and important information, and I want the same on the receiving end after they leave the ED.
Yeah, I can't help but thinking that AI could play a role in that.
Don't you think? Yeah.
Yeah.
I mean, I will say that our care was designed as an engagement for patients and the public for us to hear about, what it is that they wanted to see in a better primary care system. And what was really interesting to me is when we started to have these dialogues, one of the things we would hear again and again is about patients complaining very rightly about how it is that they didn't have access to their own records. I would say when we first conceived of our care and the kinds of things we might hear about, I actually didn't conceive that is what we would be hearing, because I didn't always think about that as part of the primary care system. I kind of think about it as data infrastructure, maybe parts of the broader system. But it was such a consistent theme over and over again. People brought out that frustration, and they brought a lot of examples about how, maybe they went to the emergency room and they'd had a test, but that test wasn't available to them or the emergency room doctor. Or maybe they, had something really quite critical happen to them and the emergency room doctor had no idea, what medications they were on or, what had happened in a different jurisdiction or even in the same jurisdiction. And so, one of the clear recommendations coming out of our care is that patients should have access to their own record in a way that they are able to share it with other clinicians and their caregiving circle. And I do think that if we focus our attention on that, the other parts of the system connection will come. Because if patients have access to that record, they can share it. And so it can become a way for emergency room doctors and family doctors to connect with each other. We'll figure the rest out. I do think that has to be an important priority for our healthcare system. And it is one, just to contrast, one of the places I went to is Catalonia, Spain. That's a country with fewer resources than Canada. And they've had a patient-held app since 2009. And so it just, says that this isn't hard. Countries have been doing it for a long time, and we should be able to do it too. And it doesn't also have to be complete, right? So even if it is medications or labs and, key diagnostic tests, that's something. Right now, most people have nothing. One other piece that I'll put forward, when I was in Denmark, on their app, patient-held app, is actually, this medication module that is an integrated module where patients, family doctors, specialists, and pharmacists all see the same information. And if a family doctor updates the medications for a patient, it is updated in real time for all of those people. The family doctor, the specialist, they can all see also the dispensing information from the pharmacist. Can you imagine the decrease in medical errors and the decrease in our own time and trying to sort out what is the true medication list for patients if we had something like that? It sounds so simple in conception, but it can have such a big impact. And to be honest, I'm not clear on why it is that we don't have something like that.
Yeah, absolutely. I want to move on to some special populations, particularly mental health and addictions, because these are populations that fall through the cracks all the time. And I just wanted to open it up to both of you. These are patients that do use the healthcare system a lot. And in emergency departments, we see these patients quite often because they've fallen through the cracks. Any solutions either here that so far work that we should be expanding on or elsewhere when it comes to addictions and mental health?
I mean, maybe I'll just start by saying that I think we need more funding for community-based services that are publicly covered for people with both mental health and addictions. People just don't have access to the care they need. We don't cover most kind of mental health care outside of if they see a physician. And we don't cover most addictions care, again, outside of if they see a physician. In some of our patients who have really complex mental health needs or really complex addictions, having a support person that's in the community can make a huge difference. And we don't fund those. In fact, you have to be so sick. So I shouldn't say we don't fund them. We hardly fund them. You have to be so sick in order to qualify sometimes for these. And they're often one-off programs. They often require that you've been hospitalized multiple times in the last year or two. But we shouldn't have to have that kind of threshold in order to give people that kind of dignity of care to be able to take care of themselves in the community.
Absolutely. The funding of these kinds of programs brings up funding in general. So, Dr. Martin, let's talk a little bit more about funding and incentives. What do you see as sort of the most effective ways to incentivize healthcare professionals to work in a way that will be best for our patients and best for our healthcare system? I mean, I know that's a big question.
Small question, Danielle Martin.
It's a big question, but I'm sure, in your work as a leader in emergency medicine and in your work, you're always crossing paths with politicians, et cetera. What are some of the good ideas out there when it comes to funding and incentives?
Well, I'll start by saying I think the research would suggest that there's no good way to pay a doctor. I'm not at all suggesting that we shouldn't pay doctors. I just, every method has its positive incentives and its perverse incentives. And so I think some of the answer to the question needs to be about what are the blended models for paying doctors and also for paying healthcare organizations and institutions that can create healthy tension. Is the incentive only to volume? That doesn't seem right. Is the incentive only to comprehensiveness? That doesn't feel likely to improve access. Is the incentive to never talk to each other or to only talk to each other? So it's somewhere in the combination of incentives, and yet at the same time, the more complex the funding model, the more you're trying to kind of fine tune all these tiny baby mini incentives, the more likely it is that you turn what should be a professional person who is well paid to do the right thing for people in front of them into a economic agent in a way that feels uncomfortable. And so there's not going to be a perfect answer to this question. And yet, certainly in family medicine, the evidence seems to be that while a pure fee-for-service method of paying physicians, especially with an aging and more complex population, creates more negative incentives than we would wish for. At the same time, a solely salaried model, if it's not coupled with really intense other kind of performance metrics and management, might create other kinds of problems. And so it probably needs to be the super annoying answer of it depends. What community you're working in, what the needs of that community are, what the patient population needs, how is the institution you work in being funded, and is there a healthy tension? There needs in the system to be incentives for access, for comprehensiveness, etc. And we probably need to worry a little bit less about the creation of super fine-tuned incentives at the level of the individual.
Yeah, I think that's where it's at, is really getting those incentives to help support everything we've been talking about in the podcast. I mean, I can say in emergency medicine, to me, it's quite clear. I've worked in places that are fee-for-service. I've worked in places where I get paid per hour, no matter who I see or what I do. And I've worked in blended models. And the blended models are by far the best for patient care. It's just the right balance. There's incentive to see patients, but there's also incentive to take good care of patients. And I think it's actually kind of insane that we don't have anything but a blended model in emergency medicine. I'm sure there's people out there who disagree with me, and I invite them to send in their opinions.
Maybe I would just build on this conversation to say I think it's also not just how we pay doctors, but who and, under what circumstances kind of thing. So, it's interesting that in places like Denmark, you actually can't just set up a shop anywhere and just charge the government when you see people. You have to, have a registration number that the region gives you. And that registration number then comes with some responsibilities that, you have to have your practice open certain days of the week, certain times of the day, that you have to see the patients on the same day. You have to participate in after hours care. So there's responsibilities and guardrails around that, which we don't have in Canada. In Canada, you can just choose to set up a clinic anywhere, open it at any time, and see any kind of patient, like just restrict your practice, for example, to just seeing people, for example, with MSK issues. I think the other thing that I observed in some other countries is, specialists are often employees of hospitals. And that actually gets to one of the big challenges that we have in Canada for primary care, which is that we cannot access specialist care in the same way that our colleagues in other countries can. And it actually really changes the kind of work that we have to do. And so part of the reason is we don't have enough doctors per population, but I think it goes beyond that. So in other countries, many specialists are employees of hospitals. And what that means is that, as a GP, you would send a referral to the hospital and the hospital would sort it out. They would figure out among those specialists who was going to see that referral and manage the wait lists. Whereas here, specialists are all autonomous for the most part, even if they're connected to a hospital. And we have to figure out who is the right one to send it to. And if they say, no, we can't see them, we have to find another one. And there's no transparency around wait times or kind of what kind of work they do. Contrast that in Denmark, where actually there's a specialist directory for the entire country that is publicly available. And patients themselves can call the specialists after they have a referral from a family doctor and then book that appointment. So just to say that there are many aspects to this that are not just how you pay somebody, but in what circumstances or who is paying.
I have to say that in the emergency department, we're pretty lucky because where I work, we have excellent follow-up clinics in pretty much any clinic you can imagine that are seen within a week or two usually. And interestingly, that's driving a lot of patients to the emergency department.
I was going to say, how many patients are you seeing because their family doctor can't get them the test or the
Precisely.
Specialist consult?
So there's
and
what
a waste.
Yeah,
what a waste.
Exactly. There's got to be a broader system that accounts for access to specialist care that doesn't just drive people to the emergency department just because they want to be able to see a cardiologist in the next week.
Yep.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricate's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricade.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
I want to get back a little bit to education and talk a little bit about how we can actually educate the public. Because we talked about how it's important to educate the public, but we didn't really talk about how. Any ideas about how we can educate the public so that we can get them on these pathways to the right care?
Well, one of the things that I really loved in Netherlands that I saw was a website that actually was developed by GPs for patients and the public. So I mentioned the Dutch College of GPs, which is this guideline producing organization run by GPs. And they decided a few years back that they would actually just hire a communications firm and take all of their guidelines and make them basically public facing. And they did this in a way that it's not just like, this is what allergic rhinitis is, but it is actually much more about, okay, you have this issue, this is what you can do to manage it on your own. And it includes not just text, but also explainer videos. So they've really thought about the communications. And when I talk to GPs there, they say that, they've observed the impact in their own practices. So, they used to get a lot more visits for something like allergic rhinitis, but people actually don't really come in for that anymore. And in that context of the Netherlands, it's actually one of the most popular health websites. I think it's such an important example for a few reasons. One, I think it shows how educating patients and the public is just the right thing to do, but it can also really influence, I think, demand. But it's also, so important in this specific time where there's rampant misinformation and disinformation online, and people don't know where to turn to for trusted advice or are assuming that they should turn to XYZ and are getting good advice when they're not. And so I'll say one other piece is, as a Canadian, I think it's also even more important in this specific time because we know that my own practice, even often when I wanted to educate patients, I'd be like, oh, they have a great handout on the Mayo Clinic website, or go check out the Centers for Disease Control in the United States. Well, in this day and age, we know that some of those sites now are not what they used to be. And that may actually change even further in the future. And so we need to build trusted content, I think, within our own country that people here in Canada can go to know how to self-manage their own conditions. So I think right now there are places that governments want people to look to, like Health 811, but I don't think we've done a good enough job actually turning those into sites where we educate people about what to do when they're sick.
Yeah, it all seems fairly simple. Hopefully there's some way we can actually implement those things relatively easily. We've talked a lot about communication and trust and relationships. One of the big ideas that you propose to improve the healthcare system is about improving relationships between patients and providers. In other words, humanizing healthcare. How can humanizing healthcare lead to improved outcomes in both EM and primary care and reduce physician burnout kind of across the board?
Yeah, I talk about this idea of 3 relationships for health. The relationship between the primary care clinician and the patient, which is sacred and the foundation to me of everything. But then there are other relationships that really matter. The relationship between the clinic and the practice population. So this idea that Tara has also mentioned about viewing your obligations as being obligations to a whole community or a region and not solely to the individual. And then I talk about the third relationship being the relationship between that practice and the rest of the healthcare system. And I think that if we think about the relationship, and we're talking about one relationship today, which is between the emergency department and the primary care practice. We've talked about the relationships between emergency medicine doctors and primary care doctors. And I think that actually There's been some really interesting work out of the US around this concept of radical redesign of health systems around relationships. Like, what would happen if relationships were the central focus of a healthcare system? It's an interesting thought experiment, and it could do a lot of good for the people who work in healthcare, because we're always on one end or another of the relationship. I think that the pressures and stresses that are experienced in the emergency department and in primary care often lead us to not be our best selves with one another. And that further erodes trust and damages care for people. And so I am interested in thinking about how to design systems to support relationships and not just individual patients who are happening to come through the door.
Fantastic. We've come up with so many great ideas in this podcast already, and I'm sure the listeners are thinking, how can we actually implement these things? How can true reform in the healthcare system actually happen? And that's another huge question. But, how can we make political change? How can we make public engagement? How can we collaborate? How do we actually do this?
Well, I'd like to propose one idea, which is, what if an emergency department were to commit that every patient interaction in that emergency department should be designed to strengthen the relationship between that patient and their primary care clinician or team? So, for example, what information would you need in order to really understand the care that that person got in primary care before they landed in your ED? And what IT systems and other things would need to be built in order for that to happen? We've talked about some of those today. But also, I don't think emergency doctors and workers realize how often what the patient hears in an interaction with you is some variant of, your family doctor made a mistake, didn't give you the best advice, or whatever. Oh, interesting, your sodium is low. I see your family doctor started you on this blood pressure pill. No wonder. And you're just thinking this is a known side effect of this medication, and the patient's thinking somebody has tried to poison me, and they've got to come back, right? They've got to come back to us when all is said and done. So really thinking about language and communication to patients and the ways in which, I guess it's a form of humility. You weren't there. You don't know what went down. You don't know what that abdominal pain looked like 3 days ago before it lands in your ED as a raging appendicitis. But also, likewise, when they come back from the emergency department, what can I do to strengthen the trust that my patient has in the experience they had in the ED, especially if they waited on a stretcher for 20 hours or whatever the case may be? So if we were to reorient ourselves in order to build trust for our patients in each other, I think that would make a really big difference in the feeling that our patients have about the healthcare system overall.
So those are some interesting thoughts about trust and collaboration. What about this sort of political change and public engagement?
And maybe I'll pick up around the patient education and empowerment. I think one part of that is ensuring patients have access to their own record. That's one way in which, the family doctor can also be kept in the loop, because if patients know what happened in the ED and have a copy of that, they can obviously bring that to their primary care clinician. But at the end of the day, I think the most important person to have the information about what transpired in the emerge is the patient themselves. So I think another aspect of the empowerment is thinking about how is it that you can involve patients in the public in your own emergency room around getting feedback and designing your services. I've learned a lot from working with patients in the public over the last 10 years, and every time I do it, my own way of thinking is challenged. I may sometimes go into it thinking I know what the problem is and what the solution might be, and then when I talk to patients in the public, they often surprise me in their perspective, and then we can more clearly get on the right page and a page together, not just me, myself, but our health leadership team, for example, by saying, okay, yeah, this is what we heard. We can align around trying to serve patients better in this way. Let's go forth and do that. I want to just say a couple of points around this. One is people are often reluctant to involve patients in the public in that kind of co-design because they worry that they're going to ask for things that are really unrealistic, or that patients are going to be really critical about what is happening. And I will say in my own experience, patients are so grateful for services. And actually, they're very reasonable when they put forward what the requests are. One important aspect of doing that well, though, is providing education to them. So you have to start out by explaining how the system works and, why things may work a certain way, and answer their questions so that when they are making recommendations, they are really thought out for the context in which you are practicing. And so I guess in summary for that, to me, through our care, I think one of the things that's been powerful has been the opportunity to try and remind all of my own colleagues and many other people in the health system that we are here to be in service of patients in the public. And sometimes we can lose that. That's how often why we went into medicine, but then we can become so caught up in the day-to-day and our own feelings about what's happening that we lose sight of that ideal of being in service. And so I think educating and empowering patients is part of that way in which we also can remind ourselves that that's what we're here for.
Absolutely. Dr. Martin, when we were preparing this podcast, we had agreed that we should leave the listeners with hope. Anything you want to tell the listeners in that regard?
We live in super challenging times for all kinds of reasons. And I actually think there are very few things on which we can reliably assume that people agree anymore. And one of those things is the critical and central value of health. It's not a bad place to start in a society, for example, to really think about how do you build starting from where you have a set of shared values. And we hear over and over all over the world from people that they value health and well-being above almost everything else. And we are so lucky to be able to work in a profession and in a system in which that is our daily work. So I'm a chronic optimist. I think actually there are tons of great things going on in healthcare systems all over the world. I think that for every example of misinformation and disinformation, of which there are many, there are also examples of tremendously valuable democratization of information, like the podcast that the two of you host. And I think there's lots to be hopeful about. And reconnecting with that core sense of purpose about why any of us went into this work is probably a good place to begin from, because it is hard to remember your own little self at the start of your healthcare journey and not feel optimistic about what that person went into it for.
Enter victorious reflective music.
Marching band and red carpet.
All right. We've covered a lot of ground on this episode. We've learned that patients don't live in silos, that the divide between primary care and the ED is really kind of an artificial one, that seamless care depends on communication, not turf, that after-hours care and virtual care is a bridge but not a bypass that can reduce unnecessary ED visits if it's done right, that we need the right care in the right place at the right time, and that relationships drive systems. That collaboration and building trust between EM and primary care teams turns fragmented services into a community that actually works for patients. Now, as promised, at the top of the podcast, we talked about 5 concrete action items that you can pilot this month to tighten your ED primary care pathways for safer and better care for your patients and to decrease the massive volumes coming to the emergency department and make all our lives better. So let's go through those 5 concrete action plans.
Number 1, redesign your ED to support trusting relationships between your patients and their primary care teams.
I think secondly, explore a virtual first or call first model that could be regionally based.
Number 3, participate in initiatives to educate the public so that they can take care of themselves and know where to go when they need help.
So I think number 4 really builds on that, and that's, empowering patients with their own information, and so ensuring that they know what happened when they were in the emergency room.
And number 5, participate in a new model that's being tried out in your local health system to reimagine what care might look like, whether that's sending doctors out to do home visits, whether it's including peer support workers in the emergency department, whether it's partnering with primary care in a new way. Those models will only get liftoff if the clinicians working in the system are willing to take a risk and participate in them.
And maybe can I put in a number 6? The bonus is going to be to consider engaging with patients and the public around understanding what's working well for them in your ED and what it is that could be better.
Fantastic. So we've got 5 plus a bonus action items that you can take to your departments in the next few weeks. So where does this all leave us? Nearly a decade ago at SMAC in Dublin, we asked if emergency medicine was a failed paradigm. Weingart warned that trying to care for both the critically ill and the system's castaways would burn us out. And Simon Carley countered that adaptability, the willingness to care for anyone, anytime, is our superpower. And I think both of them were right. Today's conversation with Tara Kieran and Danielle Martin brings that debate full circle. The real paradigm shift isn't narrowing what we do, it's widening who we do it with and how we do it best. Because our current trials and tribulations in our EDs aren't just ED problems. They're a system problem. And many of the solutions live at the interface between emergency medicine and primary care. We heard how team-based relationship-driven primary care keeps people from falling through the cracks, how after-hours cooperatives and call-first triage, like in the Netherlands, can keep low-acuity visits out of crowded EDs, how virtual care, when integrated with a patient's own provider, can improve access without driving more bounce-backs, and how shared pathways, shared records, and shared accountability close the loops that currently leak patients and staff morale alike. Continuity matters. Communication matters, and relationships between clinicians, between systems, and with patients matter most of all. Reform won't come only from another pilot or an app. It'll come from humanizing care, from building trust across the artificial boundaries of specialty, geography, and setting. That takes political courage, public engagement, and clinicians willing to see themselves as part of one connected ecosystem. Thanks so much, Dr. Martin and Dr. Kieran, for your insights and wisdom on the incredibly important topic of how we can make this healthcare system work.
Thanks so much.
Thanks for having us.
Good. And the quote of the month this month is by Paul Batalden. Every system is perfectly designed to get the results it gets.